There's no denying that the coronavirus pandemic has had a damaging impact on the entire globe. In the United States of America, more than 20,000 African Americans, about 1 in 2,000, the entire black population in the nation, have died from this disease. It's essential that we are informed about ways to stay ready and keep healthy in our communities. We have assembled experts in the medical field to give us advice and direction. This is A Race to Action, and I am your host, Stevie Mack. Hi, good morning, everyone. We're back with another edition of our podcast. I'm your host, Stevie Mack, and today we have a very special guest. We have Dr. Donald Moore, who serves as the president of the Provident Clinical Society. He's also a champion in the medical field, and we're just honored to have Dr. Moore with us this morning. How you doing, Dr. Moore?
Hi, good morning. How are you?
I'm very good.
It's great to be with you.
Glad to have you, Dr. Moore. So, Dr. Moore, I was blown away by your bio. I saw that you a graduate of Yale, the prestigious Yale University, if I'm not mistaken. I also know that you've been on the quote-unquote front lines and battlefield of the medical journey, if you will, and as a doctor and as a leader, but I know you can tell it better than I can. Can you just tell our listeners and our viewers out there just a little background of yourself and the mighty work you have been doing in the medical field?
Well, as you said, I went to Yale Medical School. I did my MD and a master's in public health. So the epidemics are obviously part of public health. Since leaving medical school, I've been a primary care physician. In Brooklyn, I have my own practice, and I've been involved in organized medicine. I've also been involved in community medicine. So I have my hands in a lot of different things. Medicine is my career, it's my hobby, it's about everything that I do.
Very good. Thank you, Dr. Moore. Thank you for telling the listeners. I felt like I learned as well. So, Dr. Moore, you mentioned that you are also into community medicine. Can you speak to that for a few moments, if you don't mind, especially considering that the Black and Brown community, if you will, was plagued, hit especially hard. Can you converse on that, if you don't mind, about community medicine?
Sure. Well, I don't think there is any profession that gets closer to the community than medicine. You know, in the old days, the doctors lived in the community. Everybody knew the doctor. Well, let me put it this way. Where my practice is now, you know, if it's alternate side of the street parking and I double park and I leave my car too long, I know I'm going to get a phone call. Somebody's going to be rapping on my door. Dr. Moore, you got to move your car. They know my car. They know me. They know what I do because I'm in the community. I've been at my practice site for definitely more than 30 years. I have moved. Patients travel all over. They go away. They come back and say, well, I have your old number and I was not clear if it was still going to work. They called and they come back. So, you know, it's a lifelong profession. It's not a job. It's a career and it's a practice. You know, I keep learning over and over. Mm-hmm. And I should say, you know, I know the subject that we're going to deal with deals with the COVID-19 pandemic. Mm-hmm. And, you know, it's once in a lifetime that a physician meets a challenge like we have today. You know, one of the things that I have done in my career is I study history. I study history in general, but I also enjoy looking at the history of medicine. I'd like to know what physicians did 100 years ago, 200 years ago, 2,000 years ago. It's that kind of profession that's been around a long time. And I think to understand, to really connect with what you do today, you have to know what's your tradition. And you also need to have some concept of where your profession is going and should go.
Mm-hmm. I love that, Doc, when you think about that concept of going back to move forward, right?
Absolutely.
So we're in this pandemic. Some states are reopening slowly, gradually. What impact have you seen as a practitioner in your community that you service? What has been the impact of this COVID-19 or this dreaded coronavirus, if you will?
Okay, so I practice in Brooklyn, New York. Brooklyn has had the highest death rate in the United States. Now, the United States has had the worst of the pandemic so far. So I'm in the epicenter of the United States, and the United States is the epicenter of this pandemic.
Gotcha.
So I am in the middle of it. The thing that I recognize in some work we did in May was all of Brooklyn is not the same. We have one part of Brooklyn that has disease rates and death rates that are 10 times the other part of Brooklyn. Same county, same borough, but we have one group of people suffering 10 times more than another set of people. So that's a major disparity. So that's disparity staring you in the face in reality.
And that, as a Brooklynite and as also a citizen of the United States, it's disturbing, and it's comforting to know someone like you is out there helping, but it's also just disturbing. So Dr. Moore, why do you think Brooklyn was hit so hard? And I also know that Brooklyn within itself, and I appreciate you for pointing it out, it's almost a tale of two cities, right? So
Absolutely.
me being a native of East New York, born in Flatbush, raised in East New York, went to school in Bedford-Stuyvesant, I kind of know, especially during the 80s and 90s, some of the things that plagued the community. I don't want to play a guessing game. So I yield to you, sir. Why do you think Brooklyn was hit so hard?
And I know you know the answer because it comes down to the social determinants of health.
Gotcha.
What are the social determinants of health? It's how much money you have in your pocket. It's where you live. It's where you went to school. It's the educational background of your parents. It's all of that. So there is epidemic disease and there is endemic disease. You know that in Brooklyn, where we have a large group of Black people, a large group of people of color, brown people, you know that endemic disease exists at a higher rate. Endemic disease, hypertension, diabetes, arthritis, all of that. So these people are suffering higher rates of disease already. But then comes the pandemic. Pandemic is just a really big epidemic, a worldwide epidemic. And what do you think is going to happen? It's going to blow those people away. And of course, in a disease that kills like COVID-19, you're going to have more people dying. And of course, when the epidemic first started, everybody, the word was, remove yourself from the path of the epidemic. Go home, work from home. Right? Well, of course, as a physician, that wasn't my orders. My orders were to go to the fire like the fireman. When the fire, everybody's going that way, I go that way. But some people can't. They can't get out of the way. They're first line workers, right? If you're a home health aide, what is your job? Your job is to take care of people. You can't do that from home. If you're a nurse's aide, you can't do that from home. If you're the delivery guy, everybody's waiting for that delivery because they're now at home. So that guy is moving twice as fast, doing twice as many deliveries. And so those are the people that are going to come in contact. Remember, this epidemic didn't start in Brooklyn. It didn't start in the United States. It came over on a plane or something like that, right? So it wasn't the people living in East New York or Canarsie that was doing the traveling. It was the people that they were serving that were doing the traveling. So those people brought the disease to the United States, but they exposed frontline people to the disease. And that's exactly what happened.
I appreciate you even weaving that visual narrative, Dr. Moore, and also really giving people that backdrop, because for so long, and some areas of the media, it appeared that this epidemic started in the Black community because we know it got hit hard. And even though that has not been stated as the narrative, at least to some constituents of those communities or some residents, that was at least a feeling. So I hope the essential workers, the way you crystallize that concept and really weave that narrative, it really made sense even for me, because I was like, I didn't know what to say, like to explain, but the way you laid it out, it's much appreciated, and it was very clear. And
if I may take it a little further. So here it is, this frontline worker goes to work doing his thing, serving, then goes home.
Mm-hmm.
All right, if you live in a house and there are 4 people in this house and you've got 2 bathrooms and 4 bedrooms, then if I get the disease, I'm just going to isolate myself. I'm going to use that bathroom and I'm going to stay in this bedroom, and the rest of my 3 other people in my family are going to stay over there and they'll bring me my food and But what is the reality of the home health aide having 4 bedrooms for 4 people? It's generally different. And I'll tell you a story. I love to tell stories.
Sure.
So I'm dealing with this lady who is bedbound at home, has 2 home health aides. One that works 4 days, the other one works 3 days. Mm-hmm. So I diagnosed COVID-19 of this bedbound, homebound patient, older lady. So I said to the home attendant, well, you've been taking care of her for the last 3 days. So you're obviously exposed. Right. So what is your home situation? She said, well, I've got 6 kids. So where is she going to isolate? Did New York City have hotels for this lady to check in back in April to say, well, you can't go home or you're going to expose your 6 kids and your husband? And, I didn't go further. I didn't have to do her mother at home, the children's grandmother. But the bottom line is, so the social determinants. So the disease comes in and then it lights and there is so much fuel to let it burn. And we get this big fire. And that's how come we have such high rates of disease in certain communities.
Wow, Doctor. Wow, Doc. This is mind-blowing, because this is personalizing it, right? And when you hear the stories, which is much appreciated, you can understand people's dilemma, people's problems, right? Now, Dr. Moore, what has been some of the things that you have done or advised those essential workers? Because unfortunately, the reality of life is that is the way they make their income, right? So we know that in order to have their income, they may face certain outcomes. What has been your medical advice to these workers, if you will?
Well, the advice to an essential worker is the advice we give to everybody, right? Basically, if you have a respiratory infectious disease, then you need 2 precautions. One is respiratory precautions, right?
Yes,
and
sir.
The other is contact precautions. You need respiratory precautions because COVID-19, a respiratory disease like influenza, when you breathe, you expire the virus. When you cough, you expel the virus. Right. If you're in an environment where the circulation is poor, the virus is going to circulate in the air for quite some time. It may travel in the air. If it's a cough where you spray, a sneeze where you spray, then those droplets are going to settle on surfaces. You touch that surface and bring it to your face, and you're going to get infected. So it's going to be contact precautions. You wash your hands every time you touch something, or you wear gloves if you're about to do something that you think is likely to contaminate you. When you're finished with that process, you throw away those contaminated gloves. You don't walk around with them and keep touching your face. So we can bring the virus to our eyes, nose, and mouth through our hands, or we can get it directly sprayed in our face, eyes, nose, and our mouth, which is why we wear a mask. And I have a thing I say: the way people wear masks in Brooklyn, they wear it like a beard. The mask is down here. Doesn't help you on your chin. It doesn't help you here either. The mask goes above your nose, tightly against your face and comes with, if it's around the ear, you make sure that it fits nicely. The difference between an N95 mask, which is what you hear the healthcare workers use, is that it fits and it really closes off
Mm.
the air from going and escaping. It doesn't come out at the sides. And if you notice, when our personal protection equipment, we use a face shield. That
Right.
shields our eyes. And of course, as a physician, if I'm going into a COVID unit where there are multiple patients where I know they're expiring the virus into the air, then I want to go in with full protection. I want to look like a spaceman. I want my hair covered. I want my neck covered. I want the face mask. I want my N95. And I want everything down to my shoes covered. We didn't have all of that in the United States. As a matter of fact, what you heard, we all heard on the news, is that healthcare workers, all healthcare workers, were deprived the opportunity to have good protection. And not just, well, these first responders. So they're out there doing the work that is essential without the essential garment. So, of course, even if I gave good advice, we as a society did not provide the personal protective equipment that we needed to deal with the pandemic. That's why our rates in New York were so high. It came to New York first. It came to New York, it came to Washington State very, very early. You heard the governor saying, send us respirators. Respirators, send us, that's the end stage of the disease. We just needed not to get the disease. We needed to prevent the disease, which basically was to wear personal protective equipment. So I recommend, even today, when the rate of the disease is much lower, that you cover your face, you wash your hands, and you limit your contact. I don't think we should be hanging out. I don't think we should be hanging out, going to restaurants and all of this. I think people should be staying home, cook your own food, be careful if you go somewhere to buy stuff and the guy is selling you the stuff without a mask, don't buy, go somewhere else, protect yourself.
Yeah. Wow. Wow, Doc. All right. It got me rethinking a lot of things. Okay. Because it seems like we're coming out of it, right? But it seems like we're still in the storm, so to speak. And I appreciate, I want to coin a phrase like, we need to have a plandemic to deal with this pandemic, right? I know it's
I like that.
We're just playing around with words. But Doc, as a medical practitioner, a veteran medical practitioner, I might add, as also a student of history, I have to ask the question about vaccines, right? Or vaccinations. And what is your take? Because in certain sectors, not just in the African American community, but in the general community, there's, and I don't want to delve in that, but there's a lot of resistance. There's some pushback, right? I wanted to hear from an expert, what is your take about vaccines? And not even, and let me just put a disclaimer, not to put you on the spot, but just out of respect for your field and not to hear the theorist, but to really hear a practitioner. What do you say to the people about that, Doc?
All right. Well, the issue of vaccine is complicated and has many layers. Now, the best scenario is we get a vaccine. The best scenario is we get a vaccine soon. However, for this pandemic, for this epidemic, there won't be a vaccine. There are no vaccines for novel epidemics. The reason why we don't have vaccines for novel meaning new epidemics or pandemics is because it's new. We never saw it before. If your body never saw something before, you cannot have an immune response to it. And that's why we're also susceptible. There are no immune people to COVID-19 walking around who never had it. So it never existed. At least we didn't know about it. We think it started somewhere in China and came to the United States. They didn't know about it. So we're all in the same boat.
Right.
So fortunately, we're in the 21st century. Fortunately, we can do gene mapping and all of that. The Chinese people said very soon after they identified that this was a virus, they found the virus, they did the gene sequence, and they gave it to the World Health Organization and says, here it is. We got it. For some reason, For some reason, after we got it, there was a testing. They developed a test. For some reason, in the United States, we decided, well, we didn't want the test the rest of the world had. We had to make our test. So initially, most of the cases of COVID-19 that I diagnosed as a physician,
Hmm.
I did it clinically because there was no test.
Gotcha.
Nobody, I didn't get the test to give to my patients. I didn't get the test to even do it to myself. I couldn't test myself. We couldn't test our healthcare workers, but we knew people were getting sick. How do we know? Because they got really sick, some of them. They ended up in hospitals, they ended up on ventilators. We know you have COVID 19. Those patients that I was diagnosing initially,
Yeah.
for actually almost all the patients I diagnosed, I had to diagnose clinically. I had to use the clinical signs of COVID 19: cough, fever, shortness of breath. And now we've added a whole lot of other things, lots of sense of taste and smell, sometimes diarrhea, sometimes you get red eyes, sometimes you get stuffy, runny nose, all of those things. So if you know an epidemic exists and you have symptoms similar to what exists,
Hmm.
what has been defined as that disease, then you diagnose that disease and you go ahead and you treat it. Unfortunately, not only did we not have the test to diagnose this disease, we had no treatment. We had no drugs. And of course, we had no vaccine. I want to answer your question about the vaccine.
No, take your
So,
time.
so we don't, we, it, the fastest vaccine that we have ever developed took us 4 years. That was the mumps vaccine. 4 years. The fastest. The average development of a vaccine anywhere in the world by any group of experts generally take 12 to 20 years. When I got into practice, when I started practicing, a new pandemic started. Just like now, this new one started. It was called AIDS. It eventually became AIDS. When I started, we didn't even have a name for it. We knew there was this thing that was infecting people and that we figured out, well, it was sexually transmitted. And I remember going to the conferences and the doctors kept saying, oh, yes, we're working on a vaccine. We should have a vaccine in 6 months. We should have a vaccine in a year. We should have a vaccine in 2 years. We should have a vaccine in 5 years. It's now 30 years, and we're still waiting for this vaccine. 30 years, and we do not have this vaccine. Not only do we not have the vaccine, we had things we developed that we thought were going to work, and some made the disease worse. So, a vaccine can enhance the disease. So
Mm.
when the vaccine comes out, I want to make sure as an individual that you've tested it and you're making sure that this thing you're going to put into my body, whether it's injection, whether it's a nasal spray, whether it's something I drink, is not going to harm me.
Mm.
How do you guarantee that? Well, you can't guarantee, but you can assure me. You can assure me that you have tested it.
Right.
You can assure me that you have tested it not on 10 people, not on 1,000 people, not on 10,000 people, but tens of thousands and hundreds of thousands of people. And even after you've done that, we may still find problems with that vaccine and we may still have to pull it.
Mm.
How do you then manufacture all of that? We've got almost 8 billion people that we need to give this vaccine if we want to give everybody the vaccine. So, the manufacturing is, a horrendous thing. And then the distribution, who is going to pay for all of that? So, it's sort of, yeah, when the vaccine comes, everything will be cool and we can go back out. So I'm just saying, you've got multiple layers, multiple hoops you've got to jump over in order to get there. Right now, there are about 8 different platforms that we could use for a vaccine. And what I mean by platforms is different ways of making a vaccine. You can take the actual virus itself and you can inactivate it, make it no longer virulent, and you can give the whole thing. The body will say, oh, that looks like coronavirus. I'll start making antibodies,
Mm.
right?
Right.
So a lot of times when we do the whole vaccine, the whole organism and whatever, we run into problems because we're responding to so many different antigens. Or we could take a little part of it, or we could take a protein from it, or we could take some DNA from it. There's so many different ways. And fortunately, we have multiple groups that are working on all different aspects. The ones that they're saying are more likely to come out first, we've never used that method to make any vaccine.
Wow.
And we've never made a vaccine for the coronavirus, for any coronavirus. So, so I'm just showing you the obstacles that we have to overcome.
Yeah. Wow. Wow, Dr. Moore. I mean,
So my thinking is for
yeah.
this pandemic, we won't have a vaccine, but it's likely that this disease, COVID-19, the SARS coronavirus, is going to come back. It's going to come back in the winter at a stepped up rate because that's just the way it is. And hopefully, I don't think we're going to have it this winter, but maybe next year, when if we still have the disease around, which I expect we will, then maybe if everything goes perfectly well, and you know that things always go perfectly well, right? Okay, so if
Yeah.
everything goes well, it is possible, but not for this COVID-19. COVID-19 means it started in 2019 and it's going to go on till probably 2021. So I don't think 2021, that seems to, you look a little surprised. Yeah,
Yeah.
yeah, well, the influenza of 1918 took 2.5 years to go
2.5
away.
years,
It
Doc.
came in three waves. I'm sure you've heard the thing about waves. It came in three waves. The first wave was kind of mild, the second wave was the big wave, and then the third wave was less than the
Less severe.
second wave.
Yeah. I appreciate your concern for the community, as well as your sense of history, which guides us to the present. As we come to the conclusion of our conversation, Dr. Moore, is there anything you want to say to essential workers about, and it could be anything you want to say, because you said so many jewels, so many nuggets of knowledge, but what's one lasting thing you could say to the listeners and the viewers out there?
Mm-hmm. Well, and my recommendation is not just for essential workers. It's really for the community. It's for everybody.
Mm-hmm.
First of all, this disease, this infectious disease that's new to us, is not going to go away tomorrow.
Right.
We can't stay inside forever. It worked staying inside, but we've got to come outside.
Yeah.
We've got to go back to work. The economy has to move.
Right.
So if there was a nuclear holocaust outside and you had to come back out, you wouldn't run out uncovered as if to say everything is cool and start touching everything and start acting the way you were acting before. You would come out cautiously. You would come out protected. So when we return to work, we need to be protected. We need to make sure that one, our employers, the government make sure that the personal protective equipment is there for all of us. If you're delivering things to people's house, you need to have gloves, you need to have face masks. If you're going from place to place, if you're a bus driver, okay, you need to, well, you see right now, half of the bus is not being used. And they tell you don't even need to pay your bus fare because they don't want you going. But you got to pay your bus fare at some point. So you've got to be respectful to that guy that's moving you back and forth, because that's how you need to get to work. So you need to wear your mask so you don't contaminate the poor guy, so he gets into trouble and can't drive your bus tomorrow. So we all have to act responsibly. Wear your mask. Give people space, distancing. Don't, just do the right thing. We know what to do. This is a respiratory infectious disease. Yeah. Don't go touching everything, and contaminating everybody. Be respectful for people who are at risk, older people, and so forth. And, when you get sick, don't hide it. I know you feel like you must go to work, whatever. But if you're really sick and you think that you could contaminate others, investigate, get that investigation done, get the test. And if you're sick and you're quarantined or put on isolation, stay quarantined or stay on isolation. So that's my, respect for all others, so that we can all get through this.
Dr. Moore, we appreciate you, we salute you, and we thank you for taking the time to converse with us. And that concludes our podcast. I thank you so much, Dr. Moore.
Steve, I really appreciate you, and thank you very much for this opportunity to talk to the people.
Please, my pleasure, my honor. Thank you, Doc.